Hello, my name is Dr. Stephen Thomas. Today we'll be doing a basic dermatology lecture on lumps and bumps. Now, regardless of your field of medicine, it's important to have an understanding of skin conditions, particularly lumps and bumps, and this is a good example. Here we have a lady with a renal transplant who for years had had an enlarging red macular rash on her back, which had been diagnosed as a fungal infection. Now, being a renal transplant patient, you can imagine how many doctors this patient had seen or how many doctors had seen this lesion, including general practitioners, hospital staff, emergency staff, renal physicians, etc. Unfortunately, the lesion is actually a basal skin cancer, which we did go on to treat by gradually burning and scraping the tumour away. Mind you, it goes without saying that treating a lesion like this would have been a lot easier had it been diagnosed a lot sooner. In the same patient, on her nose, there are also two basal cancers, which we excised with a single procedure and repaired the defect with a flap. And in this situation, again, it would beg the question, how many people actually saw the patient's nose over the period of years but never came across the diagnosis of there being skin cancers there? And of course, these things are a lot easier to treat when they're small. Now, performing a skin check is one of the roles of a general practitioner that is quite important. First of all, you need the patient's permission to do the skin check. You need good lighting, such as good fluorescent overhead lighting, natural lighting, maybe, and usually also some sort of examination light. You need exposure. And in these cases, generally we like people in their underwear. We tend not to check the groin or breast area, and we'll have people look at those areas themselves and then report any abnormal findings. Magnification is important. And then it doesn't matter how you do the skin check, as long as you're thorough, cover all the areas of the skin, and are systematic. Normally, I'll have the patient sitting. I'll look at their hands, nails, arms, face, then the anterior scalp, then move down to the anterior trunk, legs, feet, soles of feet, and then I'll have them stand facing away from me, check the posterior scalp, back, buttocks and posterior legs. But as mentioned previously, the exact way you go through this is not important, as long as the patient is comfortable and as long as it's systematic and you're thorough. And don't forget to examine the lympho-reticular system, the nodal basins, liver and spleen if relevant. Nowadays, it is virtually impossible to do a thorough and appropriate skin check without the use of a dermatoscope, only in that it provides so much more information. This is one of the older dermatoscopes where some oil or lubricant is placed on the skin and the dermatoscope is pressed to the skin. Nowadays, we tend to use the more polarized, cross-polarized light version where no oil interface is necessary, and the best dermatoscopes will have this polarized light source, which does not need the oil interface, but then you can change to using the oil interface, which can show different details. What does the dermatoscope do? Basically, there's strong illumination, magnification of at least 10 times, and it reduces light being scattered by the stratum corneum, so increases the translucency of the epidermis. In this way, you can actually see a lot more what's going on. Here we have the same lesion above and below, and on the lower lesion you'll see a lot more details. Understandably, you may think that the lower lesion looks the worse of the two, but you get to recognize the patterns, and so the bottom lesion becomes fairly obvious and looks like a benign vascular lesion under the dermatoscope. And it has been proven that it will significantly increase the accuracy when diagnosing skin lesions. Here we have a pigmented lesion which had been developing on this gentleman for about 18 months. Under the dermatoscope, a wealth of information can be found. First of all, the lesion is very irregular in the border. There is lack of symmetry. There are multiple colours and patterns. The lesion is quite chaotic, and then has added features such as this blue-white area, brown and black spots and dots, and is very irregular, and this is a melanoma. Now, different sorts of lumps and bumps we can see. First of all, erythematous base with surface keratosis. Here there are multiple lesions, and again the same pattern, erythematous base with surface keratosis on the lips. This can be present particularly on the lower lip as well, and this is called actinic or solar keratosis. An actinic keratosis is, as we said, a scaly or keratotic lesion on an erythematous background, which can be tender and or pigmented, and is characterized by partial thickness dysplasia of the epidermis. There is a small chance each year of the lesion developing into an SCC, and it is more common in fair-skinned people on sun-exposed areas and more frequent with increasing age. Here we have a nodular lesion, which appears pearly. It's shiny and partially translucent, very typical branching telangiectasia and a small area of erosion. A similar lesion on the upper lip, which has been eroded. And this is the basal cell carcinoma, which is the most common cancer in humans. Various types. For example, here there are red macular spots, and this is a superficial basal cell cancer. Interesting case, there are different subtypes, and these can be difficult to diagnose at times. In this 70-year-old gentleman, we noted that he had 2 eroded areas with some scarring or pallor around, which may have signified previous cryotherapy or scarring. Under the dermatoscope, it had the fairly typical presentation of a basal cell cancer, which was quite extensive. And with the patient's permission, we carried out 7 punch biopsies of the area, and all those biopsies showed an infiltrative or aggressive subtype basal cancer infiltrating through the skin and into the fat and the underlying muscle. The treatment for this would be excision with large skin graft, which the patient declined, and so he was referred to radiotherapy, which then healed quite well. And this is a good example of how infiltrative or invasive aggressive subtype BCCs can extend a lot further than what can be seen by the naked eye. Basal cancers, these are the sorts of conditions. There's large untreated cancer. This is a repair, a dorsal forehead flap to repair a nasal defect where basal cancer was removed. So it shows that these days we still do see quite gross pathology. Happily for that gentleman, his nose turned out fairly well. And again, the emphasis here is on early diagnosis. So basal cancer is the most common malignancy in humans and the most common skin cancer. It rarely metastasizes, though it can be locally destructive. And different types, such as the superficial, nodular, and the more aggressive infiltrative micronodular or morphic subtypes. The side of this gentleman's face, there is a circle, and when the area is stretched, it becomes apparent, the pale area, and that is a basal cancer. And this is one way of making basal cancers more apparent, is by stretching the surrounding skin. This lady has a blurred nose, and there is a small papule there, which under the dermatoscope looked like a basal cancer. We did a punch biopsy to confirm the diagnosis, and as you see, it was reported as an actinic keratosis. This is an important feature understand of where you have a correlation of clinical features and the biopsy features. It did not look like an actinic keratosis. Reporting, it was asked for the lesion to be re-reported for deeper levels to be taken, and yes, a basal cancer was found and excision was taken. The lesion was treated by excision. Just important to keep in mind that just as with us it is may be difficult to diagnose a tumour by looking at it, it may be no easier for the histopathologist. So always giving the histopathologist an adequate specimen and a clinical history so they know what they're looking for. And then if you receive an answer that is very contrary to the clinical appearance, then to go back to the histopathologist and discuss the lesion and see what else may need to be done to ensure that the correct diagnosis is made. Now, here we have a nodular area. Here is another red nodular area with some surface keratosis. And this is a squamous cell cancer, or a squamous cell carcinoma. Unlike basal cell carcinomas, these have squamous differentiation and hence the keratin on the surface. And these can be quite dramatic, and we do see cases like this not uncommonly. So the difference with squamous cancer is that it has a potential to metastasize and be lethal. It becomes gradually more common with age and cumulative sun exposure. It's more common in transplant recipients. The ratio of SCC to BCC is generally approximately 1 to 3, but the ratio will reverse in transplant patients to about 3 to 1. And clinically can present as a keratotic nodule, as we've seen, or in the last photo, an enlarging ulcer, or as a non-healing sore. Sometimes the only way to tell between an SCC and a BCC is to perform biopsy or an excision. In this lesion, we have a broad erythematous base with some surface keratosis, and here we've also got some cracking of the skin. Again, a broad erythematous base and some keratosis. And this is what's called Bowen's disease, which is squamous skin cancer, though it is in situ, so it is confined to the epidermis. And usually you'll have red, well-demarcated areas or plaques with surface scale. It may look like psoriasis. It's very common, especially on the legs of elderly women, where through wearing short skirts through their life, their lower legs would have had more sun exposure. And it can transform into an invasive SCC with time, where it penetrates through the basement membrane. In this case, this lesion, which is a nodular erythematous lesion with a central keratin plug, again, here the lesion may develop quickly over 2 to 3 months, and this is a keratoacanthoma. Given time, if no treatment is given, these lesions may resolve of their own accord. The problem is, you could be wrong, and it could be an SCC, which will only get bigger with time. And also, you do not know how big it will get before it regresses, and it can regress with scarring. So these are basically treated as SCC. And when discussing this with a patient, we call it a low-grade SCC. So it's a rapidly growing nodule, can become large and heal with scarring. Even histologically, it can look very similar to an SCC. So a biopsy usually does not help distinguish the two. And it's usually best to excise the lesion, or it can be treated with cure and curettage if the area is, say, too difficult to excise. A good example of that would be the lower leg in an elderly person, where an excision may cause unwarranted morbidity. Good idea for us all to know how to do a punch biopsy, which is a very simple procedure. The skin is anaesthetised with a local anaesthetic, and the biopsy is used in a rotation manner and pushed into the skin to remove a small piece of skin to be sent to the lab. Usually nothing than a 3 to 4 millimetre diameter biopsy should be performed. And it's a good point now to mention that never partially biopsy a pigmented lesion, because if a pigmented lesion is, for example, a melanoma, you may miss the melanoma component if it's combined with a benign nevus. And secondly, the histopathologist diagnosing melanoma may be difficult, and sending only a small proportion with a small biopsy may make the diagnosis even more difficult. Lesions can also be biopsied by injecting them with local anaesthetic and then shaving the lesion off. And then, of course, you can do incisional or excisional biopsies. Now, we'll just move through this reasonably quickly. So, nevi or moles are composed of nests of melanocytes. Some may be present at birth, and most develop later in life, particularly in childhood, and are related to sun exposure. There is a family tendency to having large numbers of nevi or moles. And again, these are different types of nevi, and the diagram here displays where the melanocytes are located. Not very important to know the distinction unless you're a histopathologist. Now, here we come to a little bit of a contentious issue which has been changing. These lesions are irregular, they are asymmetrical, irregular border, multiple colours, and not melanomas. And they've developed the name of dysplastic nevi. Generally speaking, the term dysplastic nevus is not helpful, and currently what we do, first of all, there's two different classifications. Are we talking about clinically dysplastic or histologically dysplastic? So clinically dysplastic basically means it's a big nevus that looks like a melanoma but is not, so it's very unhelpful. And so we basically say or go to the term of, or the thinking, is this nevus possibly melanoma or not, rather than is it dysplastic or not. So the term dysplastic clinically is not very helpful. Also histologically, again, it is, for a number of reasons which we won't get into, is not very helpful. And again, with an excision of a lesion, it's the better reporters will say it's either a benign nevus or a melanoma, or they're not sure, rather than using the term dysplastic nevus, which will mean different things to different people and which can be confusing. A 14-year-old boy may be brought to you and the mother says that his moles have developed white areas around them, and that's a halo nevus, where there is an autoimmune attack on the melanin pigment around the nevi, producing the pale area, and with time these nevi may disappear altogether. A young child with a very dark, quite regular spot, which has a bluish discoloration, or an elderly person with a regular bluish discoloured papule in the hairline. And these are blue nevi, where the melanocytes are deep in the dermis, resulting in this blue discoloration. And these are benign. However, a metastasis from a melanoma can look identical to this. And so the history goes a long way. So if this person says that, yes, that's been there for a long time, then we're not overly worried. Though, unfortunately, sometimes there is a blue nevus and the person may not be aware of it. And so one needs to keep in mind that this could be a melanoma, and just to keep that in mind in the differential diagnosis. Melanoma. Clinically, we all know about the A, B, C, D and E of asymmetry, irregular border, colour variation, diameter greater than 6 millimetres, which is not true, enlargement, elevation, environment. Has it enlarged? Has it risen? Is it different to the spots around it? Is it an ugly duckling? And probably one of the most important features now are dermatoscopic criteria. If you're going to be checking skin, it is important to learn how to use the dermatoscope, because this will largely assist your diagnosis of pigmented and non-pigmented skin lesions. With melanoma, the prognosis depends basically on the Breslow thickness, the thickness from the granular layer of the epidermis to the deepest invasive area of the melanoma. Here we have a large irregular lesion, asymmetrical, areas of different pigment, again on the lip, and this is in situ where the melanoma is confined to the epidermis, has not gone through the basement membrane, has become thicker and is a superficial spreading melanoma where it is invaded through the basement membrane. Nodular melanoma, these can come up rapidly and have a poorer prognosis, because by the time you diagnose a superficial melanoma, hopefully it is only relatively thin because it's given itself away by this large wide pattern. However, nodular melanoma may not give itself away and may become deep before actually being diagnosed. And then the amelanotic melanoma, which can look just like a red spot, which can be difficult to diagnose. Here we have a typical irregular lesion on someone with multiple colours, asymmetry, chaos, and in this case was just a dysplastic nevus, not a melanoma. And again, I shouldn't use the term dysplastic. Basically, it is benign. So that was removed and found to be benign, which makes us look at, if in doubt, cut it out. Melanoma, as we've broached on in the previous slides, lentigo maligna, melanoma in situ, Hutchinson's melanotic freckle. Histologically, they can be different, but for a general practice, we tend to view them very similarly. They're slow, thin, especially in the elderly, and usually too thin to metastasize. They are too thin to metastasize, provided the diagnosis is correct. The superficial spreading melanoma is the most common form. Nodular can be relatively rapid growing with a predominantly vertical growth phase and therefore worse prognosis. And then there's acral. These are rare and most prevalent in the Asians and Africans, where it is basically on the hands and feet. The difficulty with melanoma, it can be lethal with a thickness of much less than 1 millimetre. Mainly affects Caucasians, more common with increasing age, though important cause of mortality under the age of 40, and causative factors such as sun exposure, sunburn, especially in childhood, genetic predisposition, number of normal and dysplastic nevi. Again, we're using that term dysplastic nevi. We're probably now more just using the term total number of nevi. Treatment of melanoma generally is excision. Sentinel node biopsy is important to be aware of. Radiotherapy has a small role. There is an incredibly large role, an increasingly large role of biological agents for advanced disease. But the mainstay of treatment is basically prevention and early detection. We'll start looking at some lumps and bumps now. Here we have a pinky purple indurated lump on the skin, which when you press it, it causes an indentation. Under the dermatoscope, you may have a brown, what's called reticular pattern around with some central fading, and this is called a dermatofibroma, which is basically a small area of scar tissue of unknown cause, maybe an insect bite, an ingrown hair, and is benign, and shows this dimple sign. Here we have small papules, probably on a child with central umbilications. Can happen in adults, but usually more in children. molluscum contagiosum, which is caused by pox virus. There's a number of treatments here, such as cryotherapy, enucleating lesions with a 19-gauge needle, cautery, and also imiquimod cream, which has to be a reduced strength, usually bought from one of the children's hospitals who mix it up. Plantar surface of the foot, we have indurated areas where the footprint has been obliterated by this growth. Here they are exophytic on the dorsum of the hand, and these are viral warts. Viral warts can be quite recalcitrant. There are numerous treatments, and they are contagious. So the treatments: observation, plus or minus occlusion, wart paints, cryotherapy, cautery and curettage. Whichever treatment is used, you need persistence, because, as we said, the warts are quite recalcitrant and readily recur after treatment. Here we have a large brown warty spot which has a stuck-in appearance, like it's basically been stuck there. It looks like a paintbrush on end which has dried paint. And these are seborrheic keratoses, which are benign, very common lesions which occur in skin, particularly as people get older, and the flat ones of these can be particularly difficult to differentiate sometimes from melanoma. If the lesion is changing and it looks like a seborrheic keratosis, it is worth removing it. That's if it's changing or irritating, as sometimes it's not a seborrheic keratosis, or there may be malignancy developing within it. Here we have the foot of an elderly person with lots of little white, well-circumscribed scaly areas. And this is a cousin of the seborrheic keratosis called the stucco keratosis, which again is benign. When you're checking the blood pressure in your elderly patients, you'll almost certainly find brown freckle-like lesions, dorsum of the hand. And again, these are benign. They are solar lentigo, pigment-induced, sun-induced pigment, benign, and again, can sometimes be difficult to differentiate from melanoma. The neck of this young man, there is a palpable lesion. This is lipoma and can be differentiated from sebaceous cysts in the fact that the lipoma is softer and mobile under the skin, while a sebaceous cyst is tethered to the skin and may have a punctum. Here is an example of a sebaceous cyst or an epidermal tumour where the superior part of the tumour is joined with the skin and there is a punctum. Sebaceous cysts and lipomas are benign and can be removed if the patient would like that. Multiple lesions on this person's abdomen. They are quite red. And these are Campbell de Morgan spots, benign vascular lesions. People may present to you with a tender keratotic area on the edge of the ear, and this is basically a pressure sore from sleeping on the area, and it's called chondrodermatitis nodularis helicus, or a painful nodule of the ear. These can be treated through conservative measures of, say, not sleeping on the area, having a soft donut-shaped pillow, or they can be excised, which may also give relief. Pyogenic granuloma usually is a nodular area which is red and shiny, and it is basically massive granulation tissue from some sort of aberrant healing process, often related to moisture. These can be easily treated by an injection of local anesthetic, shaving the lesion off, and sending that for histology and then cauterizing the base either chemically or with a hyfricator. The specimen must be sent to the lab as, again, malignancy can appear in the same fashion. Thank you. That's the end of this presentation. I hope you've learned something. And if you have any questions, please leave a comment down below. Thank you.